Yes, big welcome to everybody. Thank you for joining us to the Pathway Partnership Programme breakfast briefing. My name is Chris Sargent. I'm the Medical Director of Pathway and also the Clinical Lead for the Pathway Partnership Programme. So over the next 45 minutes, we hope to explain the programme to you and encourage you to think about how the programme might be able to help you in addressing the health inequalities in your area for the inclusion health groups. We're recording this session, so please let us know if you're not happy with that. Feel free to keep your camera off if you don't particularly want to appear on the screen. We've contacted you because you're somebody that we've been in contact with in the past about the Pathway Partnership Programme, what it can do, or somebody that we think would like to work with us, or there's some area that you might want to address with us. And we're very happy and open to ideas about how we can do things in inclusion health. If you could please add your name and organisation and job role in the chat, that would be really helpful. We've got all your email addresses, but we don't always know what area you're from or what your responsibilities are, so that would really help. And if you could put any questions you have in the Q&A function in the on the top bar there, then we'll try and get around to those and answer those as best we can, either as we go along or towards the end. And we will try and collate the questions as well. If we don't get the chance to answer them, we'll collate the questions and send out some answers all together so everybody can see those at the end. So when I've finished talking, we're going to move on. We're going to go through the whole programme. At Pathway, we think the lived experience voice is very, very important. We always try and prioritise the lived experience voice. We're very lucky and privileged to have Gareth Murphy from our lived experience group with us this morning to talk about the lived experience perspective. He's in the middle of moving, both house and job, so we're lucky to have him this morning. I will talk a little bit about the problems that we're trying to help you solve. Then we'll have Paul Hamlin, Project Manager for the Pathway Partnership Programme, about how we can help. Sophie Kerner, who's also one of our project managers, about how we support teams through the Pathway Partnership Programme. Theo Jackson, our data lead on outcomes for the teams, and then we'll be joined by Steve Cox, who's a commissioner from Devon, to talk about the commissioner perspective on working with the Pathway Partnership Programme. Then I'll wrap up at the end, answer any questions if we have time, and then talk about how you can get in contact with us to work with us in the future. So without further ado, I'll hand over to Gareth for the lived experience perspective.
Thank you, Chris. Good morning, everyone. Thank you for joining us. We really do appreciate it. My name is Gareth Murphy. I am an expert by lived experience to say that I have experience of homelessness, multiple unmet needs, and I'm in recovery from addiction. I currently work alongside the homeless health team in Hull Royal Infirmary. And in 2016, 2017, I found myself repeatedly admitted to hospital due to alcohol and drug overdoses. Now, stigma sadly still does persist. It did back then and it does now. And I was in that hospital for 2 years before a doctor was kind to me. What happened was basically I went into hospital in 2017 and I'd been in and out, getting treatment, coming back out, periods of homelessness, mental health, things like that. And what happened in 2017 was a doctor just reached out and said, "We're not here to judge you, we're here to treat you." I had paid before that into the system like everyone else. And when things fell apart, I did not need judgment, I needed support. Now, this is what the homeless health team does, who now I can call my colleagues, who I'm very grateful to be alongside of. They create a safe space for people to begin healing. Every member of the team embodies a powerful blend of professionalism and humanity. The values that the homeless health team brings is fantastic because they understand the person behind the illness, whereas medical professionals are not trained to treat. They're trained to treat the disease, not to look at the person and what's going on. Now, a lot of people who are experiencing homelessness continue to face stigma. They have trauma, things that we cannot even begin to imagine a lot of people have gone through. What the homeless health team do, they'll look at the individual, they'll try and talk to them, try and understand them, show them a bit of compassion, dignity, caring, And above all else, they'll treat them like human beings. Now, we live in a society where we like to think that happens every single day, but sadly it does not. I can say from my own experience that is the case. And now as a professional, I can also say that I see that on a daily basis. That is not to say that the National Health Service is not fantastic in what it does, but it's obviously very underfunded and it struggles to deal with complex patients, those that the homeless health teams do work with. And they save so much money when it comes to taking people, seeing them in ED, things like that. Now, I cannot say if there was a homeless health team in Hull Royal Infirmary in 2016 and 17, whether that would have led to me seeking support sooner. But what I can say is as soon as I was shown compassion, that totally changed my life around. And now I'm able to take that with me and do that in my day-to-day life. Because I work in Hull Royal Infirmary at the moment. I am going to be working in the criminal justice system, and that's what the power it does when you treat people like human beings. It gives them hope. It was quite ironic, really. I watched Big George Foreman last night on TV, and in there, a trainer just saw him as somebody who needed some hope. And with that, obviously became a big star, and obviously the amazing life, and that's what we all need, really. I thought it was a very good timing to watch that, because we don't achieve anything on our own, and if people are just coming out of hospital, they're getting patched up and kicked back out again, then it's just a vicious cycle. Whereas the homeless health team do actually help support people and do look at the person behind and what is going on. And not only that, they will also link in with other services like MAN, like drug and alcohol rehabilitation. They'll also link in with council services, and all that will be explained later on. But I just wanted to give you a bit of perspective of what can happen if somebody's just given a bit of treatment, a bit of care, and a bit of support. I'll pass back over to Chris now.
Thanks, Gareth. If we can move the slide on, please. So, who are we? So, who are we to be talking about this? So, Pathway is a unique national charity working to improve the health outcomes for people experiencing homelessness and the other inclusion health groups. We do that. Obviously, you have to pick your way that you do that. So, we create and support specialist Pathway hospital teams, which you will be hearing more about a little bit later. So those are in-reach teams that go into hospitals to find, treat, support and plan the discharge for people experiencing homelessness. We promote the lived experience voice because we believe that the person who's going to be able to tell you the best about how to do something is the person who's using that service themselves, and they will certainly be able to tell you where you're going wrong. We do regular reporting, so we collect data from all of our teams. We also act in a national function to produce national reports like the annual barometer report, and we produce an annual report on the Pathway Partnership Programme as well, which collates all the data from all of the teams around the country. And we try to use our position to influence at all levels, so at local level, right through up to national level, government level, and even to a certain extent international level. We've been able to sort of influence other countries to have pathway teams in other countries as well, like Australia. So we try to bring people together internationally at things like our conferences to really spread the word about inclusion health and try to get better services in for people, better support. Thanks, Paul. Next slide. So what we're trying to achieve. So ultimately, we're trying to reduce these extreme health inequalities and inequities facing the inclusion health groups. And those are, people are not familiar with the term inclusion health, that's the health of people experiencing homelessness, people who sell sex, vulnerable migrants, and Gypsy Roma traveller groups. We do that by, first of all, trying to look at what there already is in an area. So collaborative working, bringing services together. We often find that people working in the same sector, in the same area, often don't know each other. So bringing people together, making sure that services are right for the people who use them, so that they're accessible, so they can actually get to them, get to the people they need to get to, that they're appropriate and run in the right way, and they're trusted by the people who use them, because if they're not trusted, they won't be used. If there are gaps, helping areas see where those gaps need to be filled in, working across those gaps so we have people Commonly pathway teams who are working in the community, also working in the hospital, which is pretty rare, but has a big effect in terms of people being able to see their patients in different settings, people feeling those people are following them, gaining that trust, as I mentioned earlier. We co-design services, as I say, the people who use them are the ones who know, and reducing the need, ultimately reducing the need for admission to hospital and readmission to hospital. We commonly find that people experiencing homelessness get stuck in a repeated pattern of being patched up in hospital and discharged back out to the situation they came in from. What we want to do is try and stop that and use the hospital admission as an opportunity to really change what happens for somebody. Next slide, please, Paul. So what are the problems? So ultimately, it's very poor outcomes for people in these groups. So we know the standardized mortality ratios or death rates are 10 times for the people experiencing homelessness than they are in the general population. And there's a background there of premature frailty. And we also know that people die early as well. So they age early and die early. We have these repeat admissions and repeat attendances at A&E. So we often see that people going to A&E 10, 20 times more often than the general population. The systems in place don't work for our populations very well. So discharge to assess, where are you supposed to assess somebody if you discharge them out to the street? Duty to refer is not done, so people don't know about it or don't do it. The guidance we do have isn't followed very well. There's poor joint working between different parts of the system. The evidence base that we have, so for pathway teams, for intermediate care, from the NICE 214 guidance, isn't followed. People are not aware of it. Staff are poorly trained on the areas that affect people experiencing homelessness and the other inclusion health groups. So treatment for opiate withdrawals, mental health treatment in physical health settings are not well done. People don't know about how to get in touch with housing. Staff end up feeling overwhelmed and in need of extra support. And the ultimate problem is we know that at least 4,000 people a year are discharged out of hospital onto the street. And so that's about 10, 11 people a day. It's probably double that because that evidence comes from a freedom of information request and only half of the trusts responded to that. So it's probably more like 8,000 people a day. So that's 8,000 people a year. So that's 8,000 opportunities missed to intervene and change things for those people, having been in an expensive part of our health system. I think I'm now going to hand over.
Thanks, Chris. Hi, I'm Paul. I'm a project manager for Pathways Partnership Programme. So how can we help you? So we have 3 options in our partnership programme. Homeless health needs assessments, our bespoke consultancy work, and also the support that we can provide to set up and run pathway hospital teams, which we're going to talk to you about in a little bit more detail. So I'll just start with needs assessments. So needs assessments have previously been commissioned by ICBs and NHS trusts to help them understand the health needs of people experiencing homelessness and other inclusion health groups in their area. They also help identify gaps in service provision, including how hospitals care for and support discharges of people experiencing homelessness. We often make recommendations for improvements to services, and we can also forecast potential health and cost improvements if a pathway team or other service changes are implemented. Our consultancy work is more open-ended. So commissioners and system leaders, you can tell us your needs and we'll develop a bespoke offer of support for your area. So a needs assessment might not be needed if you've already done some scoping and are aware of some of the local gaps and issues already. Our consultancy work is collaborative, so we're very happy to partner with local experts and organisations to deliver the outcomes you're interested in. And the third service we offer through a partnership programme is support with the scoping, implementation and ongoing operations of homeless hospital teams, which we call pathway teams. So in a moment, Sophie is going to tell you a bit about how we support our teams, but before that, I'll give you a quick overview of this service model. So what are pathway teams? Pathway teams are hospital-based, clinically led, multidisciplinary teams. They're clinically led, so they've got nurses, GPs, OTs and other specialists, as well as housing and care navigators, often people with lived experience. And they also draw on other expertise. For example, some have got access to legal advice for housing and immigration. And what these teams do is they find, support, clinically advocate for and plan safe discharges for people who are experiencing homelessness in hospital, with an overarching objective of improving health outcomes. So while the model is hospital-based, there are quite a lot of local innovations of this core service. For example, some teams do more outreach into the community, looking at admission prevention work with high-intensity users, and several have also got step-down or intermediate care services for people leaving hospital. So who's a typical pathway patient? So inclusion health groups have got high rates of physical and mental health problems and often substance misuse issues. Our patients often face stigma and systematic exclusion from services, and they often have complex social and support needs on top of complex health and care needs. And this complexity can't successfully be resolved without multidisciplinary team input. And without a pathway team, what we find is there's often a lack of coordination around all these issues. So where are we working currently? We support a network of 18 pathway teams. Our partnership program has been going for 6 years now. So we currently support 5 teams with our kind of high level of partnership program support. We supported up till 9 until very recently. We also provide a lower level of support to a wider network of legacy teams that preceded the program and some previous partnership teams. And then lastly on this map, the blue dots are where we've been engaged by commissioners on a consultancy basis or completed needs assessments. And now I'll hand over to Sophie to talk about the support we provide to teams.
Good morning, everyone. I am Sophie Kerner. I am the mental health occupational therapy policy and practice lead, and also lead with some of our lived experience work as well. So I'm going to be talking about the support. We kind of have 4 phases of support. The first couple really Paul has been talking about already. So that's about building the pathway teams and the needs assessment. So the first bit is around working with commissioners around building a case. So working out who the early stakeholders are and working to engage them with the commissioners. If a needs assessment is needed, then we can provide support with that. And then also we have lots of experience in supporting around building a business case to actually get a service provided if it's needed. The next part that we might be supporting with is around service design, and that involves developing a service specification for your specific service and the needs there. Identifying partner providers. By that we mean the hospital and the other organisations that might be working and maybe providing the employing some of the staff for the teams. We'll also work with the wider local stakeholders to try and get those involved. So that might involve housing, social care, voluntary sector organisations that might be providing parts that would be working alongside a team. And then we work towards having a partnership agreement in how we would all work together. Can I have the next slide now, please? The next part is once all of that has happened, we would support with around implementation. And this is we can help with recruitment, whether that's helping with we've got a set of job descriptions that have all been banded at the right levels. We can be part of interview panels. Some of that we may also be able to engage someone with lived experience to be part of a lived experience of an interview panel. And then we can help with the comms strategy around the team, and in particular around developing a launch event for the team when they are about to start. We also can advise around the kind of practical needs of a team, and this may be things like accessing the right computer systems. We know that our teams are often made up of different partnerships and different people from different organisations, so making sure that everybody has the right access to the systems, and also honorary contracts. We can help with advice around what kind of office space and some of those things that teams need. We also, and Theo will be talking about this in a little bit more detail later, but we set up what a data collection process might look like so that we can kind of on an ongoing basis collect data which we have across our network, and then also gathering that baseline data for the team as well. We also offer a 2-day team induction, and that can be open to a wider team as well, if we've had commissioners join those inductions before as well. Can I have the next slide, Paul, please? And then once a team is set up, we have they have access to our national network of support, so where we have masterclasses that happen on a monthly basis. They have access to all of the teams that are part of our PPP network. We have a conference every year and they get tickets to that. They have opportunities to network with other people who are doing similar roles to them. So we have a nurses network, a GP network, a housing worker network, and an occupational therapy network, and others within our wider faculty. And also, I think the being part of that network really helps with system change, with kind of the power of that voice. For the individual teams, we've offered direct support around the team training, which I already mentioned. We have a structured monthly call where we can talk about any challenges that the teams are experiencing, and we give advice around that. The teams are also able to contact us for any ad hoc specific advice. We do an annual quality visit where we go and we visit the teams and really kind of help with any specific challenges that they may be having there, but also just to see how they're running. Each of the teams are slightly different, so it's useful for us to see how they work in a local area. We have support around quality improvement and service development, and we also have our online operational manual. We can also help teams to set up and access reflective practice or legal advice, which a lot of the teams have access to. When they have access to it, is it around immigration or challenging housing, and sometimes social care. And all of that is supported by, we have our multidisciplinary team, which we hope reflects the teams that we're working with as well. And I'm going to hand over to Theo now. Sorry. Thank you.
Thanks, Sophie. Morning, everyone. My name's Theo Jackson. I'm Pathways Research and Data Lead, and I'm going to talk you through some of the kind of key data and outcomes that we've seen from across the partnership program over the past year. So firstly, as Sophie briefly mentioned, I just want to talk a little bit about the kind of support that we provide across the program to the teams in terms of data. Really, we do a lot of work that's ensuring the teams are firstly being able to evidence their impact and evaluate the services. And we also have a quality improvement data framework so teams can look at key quality indicators, for example, the rate of self-discharge for patients seen by the teams, in an effort to be continuously improving as well. So we have our recommended data framework, and this is based on the experience of our team of working in this sector, key data points to be looking at and monitoring, and key outcomes as well. We do a lot of work with local IT and business intelligence teams to actually support developing data collection processes within the clinical systems that are already being used by the teams. We conduct the data analysis and reporting where it is applicable across the program. We conduct data analysis, produce quarterly reports for teams and commissioners, again looking at the impact, but also with that quality improvements perspective. Sorry, I think somebody isn't on mute. If you could just mute yourself, that would be fantastic. Thank you. Paul, I think it might be you. Thanks. So we also provide a range of materials for teams to collect case studies and patient feedback as well. This is a really important part of evidencing the impact as well. Provide support to produce detailed evaluation reports on an annual basis. And we also work to produce economic and return on investment analysis as well. So we really want to help the teams to show their impact and drive quality improvement processes as well. Next slide, please. So taking a look at some of the key data points from over the past year, starting off just with the referral numbers that we've seen across the programme. So you can see there in 2023-24, over our 8 teams, we had 3,377 individual patients supported by the programme. It's an average of 422 per team. We do see some teams seeing more and some teams seeing less as well. Main point there is just that there's clearly a really high level of need for these services where we've set teams up and they're seeing a lot of patients, really showing the need for them. As you can see from the chart on the left, there's over 2 years, there's been an increase in the number of patients being seen by the teams. You know, we're all aware that the numbers of people experiencing homelessness are continuing to rise. So the level of need for these services continues to increase as well. And then on the right, we just have some very high level needs of the patients that were seen by the team. So over 60% with substance misuse needs, 60% with mental health needs, over 40% with dual diagnosis, and around 40% with safeguarding concerns as well. So this just demonstrating, as Chris talked about, the complexity of the patients that are being seen by the teams and the real need for that multidisciplinary service to actually meet the needs of these patients. Next slide, please. So one of the key kind of outcomes that we look at across the teams is the impact on housing status. So teams will provide a range of clinically led housing advocacy to try and improve people's housing status when they're leaving hospital. And obviously that's really important because without an improvement in housing status, it's going to be really hard for people to improve their health. And without that, they'll continuously need to keep coming back into hospital. So some of the key data points we have, 89% of all consenting patients received some form of housing advocacy, whether that was the statutory duty to refer or an alternative route. And what we find with the duty to refer, as Chris also talked about, is that when you don't have a specialist team, it's really not being done. And sorry, I got slightly distracted then. And it's actually a statutory duty for hospitals.
No.
Sorry, can somebody go on mute, please? Thank you. So what we've seen as a result of this housing advocacy is some really impressive housing outcomes. We've seen a 43% reduction in the number of people who are rough sleeping, a 21% reduction in the number of people sofa surfing, and a 62% increase in the number of people with temporary accommodation placements. We also see those reductions in rough sleeping and sofa surfing are also due to people being secured appropriate discharges to places like care homes, specialist supported accommodation, and to intermediate care step down placements as well. So really ensuring that people are discharged to the right places. And especially in the context of just how challenging the housing system is at the moment, those are some really impressive outcomes we've seen from the teams. Next slide, please. Some of the other key quality outcomes we've seen over the past year. So 85% of all the patients seen received a holistic assessment and had a comprehensive care plan developed. 97% of patients were seen and assessed within 48 hours of referral. So that's obviously really important to ensure very timely access to specialist care. It also means there's more time for effective discharge planning. So that's a really positive quality indicator. And we also saw 255 patients were supported to register with a GP when they didn't have access to a GP on leaving hospital. And that's obviously really important for ensuring continuity of care into the community, facilitating people's recovery and preventing the need for them to come back into hospital because they're actually getting care in the community as well. Next slide, please. And lastly, we can take a quick look at some of the financial benefits that we've seen across the Pathway programme over the past year. So I won't go into so much detail about the calculations here, but you can get in touch and I'm happy to provide information of how we work these out. Essentially, what we see is that by providing a higher quality of care, improving the quality of discharges, it reduces the need for people to come back to A&E and be readmitted to hospital as well. And that generates financial benefits in terms of costs avoided for admissions and attendances. And so we look at this in a few different ways across the programme. Firstly, we've looked at we've produced some costed case studies. So we've looked at patients who were very frequently attending A&E, being very frequently admitted as well. And what we've seen is that comparing a year period before being seen by the team with a year period afterwards, we've seen avoided costs for individual patients of between £6,500 and £17,500 over a year period due to those reduced reattendances and readmissions. We've also done some analysis of secondary care data across a wider group of patients, so all of the patients seen by a team, for example, and we found very similar findings, so a 66% reduction in the average number of A&E attendances per patient and a 61% reduction in emergency admissions per patient, again, due to that improved quality of care and improved discharges as well. And lastly, there are also avoided costs in terms of bed days, being homelessness, attending hospitals. So there have been a few studies of the pathway model previously that have found overall a 30% reduction in inpatient bed days from this patient group. And so when you calculate that across the average number of inpatients seen by a team, which is 253 patients, the average length of stay for an unplanned admission being 8.3 days at £901 per bed day, that's a possible cost in bed days of £1.9 million. But if we apply that 30% reduction, we see that a single pathway team for a single hospital can generate up to £570,000 in avoided costs. And that's just in reduced bed days alone. It doesn't account for reductions in A&E attendance as well. So overall, some really impressive financial benefits that we're seeing based on that improved quality of care, improved discharges as well. So just to summarise all of those points, firstly, there's a really high level of need for these services. The level of need is increasing. Our teams are seeing more and more patients over time. We're seeing some really impressive outcomes in terms of quality indicators, in terms of improving access to primary care and improving housing status as well. And as a result of that heightened quality of care, we're seeing some significant financial benefits across the partnership programme. So thank you. I'm going to pass back to Chris now.
Thanks, Theo. And I think we have Steve Cox on the call.
So Steve, I am here.
Hi, Steve. Thank you. So Steve is a commissioner from Devon, who we worked with on the implementation of the Plymouth team. And we just thought it might be nice for you to hear from a commissioner about their perspective on working alongside the Pathway Partnership Programme. So, Steve, over to you.
Okay. In my discussions with Chris on this, it was like, just tell it how it is. You don't need any slides. Just give us your experience as it is, as if we're over a coffee or something. So I'll do my best. But we've been working with Pathway about 3 to 4 years, and in terms of the stages, very much heavily involved in helping prepare the business case, the service spec, looking at what was already in place within Plymouth. And then what I think was quite critical was supporting us through the implementation stage. The business case had been approved and there was a strong political will for the service to be established. But like a lot of systems, capacity is stretched. And so though the business case had been signed off, it was sort of awaiting implementation. I was appointed to lead the implementation. But what was a fantastic asset was to work alongside Pathway, because you had a trusted friend who'd done this before and therefore helped us plan, interview, basically help deliver the service to enable it to go live as soon as we possibly could. There's a strong, overwhelming need for this level of service. We had sort of some services in place, but they were fragmented. We had a specialist GP service. We had a hospital housing team, but none of it was really joined up. And what Pathway has enabled us to do is to bring that together. So in terms of the sort of threefold ambitions of our service, it's to be in the community and avoid admission where possible. So we have GPs and community nurses working in the hostels, supporting patients so that they don't end up in hospital. We also have the in-hospital team, and we do ward rounds, work alongside the actual wards, and all of this has been supported throughout by Pathway. And then we have, and I think this is a big difference, is this safe discharge. And again, because of, I think, the legitimacy of the work we are doing and the legitimacy that being a Pathway team provides, we're able to have clinically led discussions in hospital about whether someone's safe to be discharged and where they should be discharged. So the effect on the service and the number of people that have gone back to rough sleeping, we've seen 300-400 people in the time we've been live, and only 2 of it returned back to the street. and that was voluntarily. So all alongside this, both pre-implementation, during implementation, and post live, we've worked hand in hand with Pathway. So they've been, I'm not here to be an advert for them, but we couldn't do it without them. We think it is an essential resource. I asked the clinical lead, what's his consideration for the value that we have been a Pathway team, and I think the strongest comment was that working in inclusion health it's an emerging discipline, but it's also a lonely discipline. You're often perhaps misunderstood because it's not so widely known, but having the wider community of fellow practitioners that Pathway opens you up to through the regular meetings, the conference, the faculty, it gives us a sense of, I suppose, togetherness that we wouldn't be on our own. And also in times of challenging financial constraints, Pathway, it gives it, it's not just something we decided to do and designed ourselves, and it doesn't have, I suppose, the necessary sort of backing, legitimacy, authority, but Pathway gives us that. And I think the service that's been live about 2.5 years now stands up in that perspective. The results that we're achieving, and it's not just about admission avoidance, about reduction of bed days, a reduction of cost. Clearly all that is important, but the journey that we've been able to take patients on from being frequently attending emergency departments to actually being in a place of safety and in decent housing is really been a tremendous achievement that the team have done. So that's just my few thoughts on it. But I'd recommend all of this and more. We've got a strong team. We've got a number of positions in place, but there's always more to be done. And as Theo has described, the demand is growing, and it's not going to get any better in the short term. So that's just, as I say, a few observations, and happy to take any questions if you want.
Brilliant. Thank you very much, Steve. Yeah, we'll do some questions at the end, I think. I just thought we ought to say, if you do, we've got a few minutes now. We've got 8 minutes, but if you do want to contact us following this, you can contact us via Pathway, or probably best to email me, christopher.sargent@nhs.net first, as Paul is going to be having a few days of well-earned holiday. But if it's after the next couple of weeks, then Paul's email address is there as well. We'll send out this presentation to you all along with any other questions that we get from the second event that we're doing later on today. So has anybody got any questions? We've answered a couple of questions in the chat already, I think. Anything anybody wants to ask? You can, as I say, you can either put them in the Q&A, there's a Q&A function there at the top in the toolbar, or you can put them in the chat. If there's anything that anybody would like to ask anybody who's done the presenting this morning. So there's one here from Rebecca Murphy. Many thanks. Have you any outcome reporting you can share? This is to Steve. It would be fantastic to read more. Many thanks, Rebecca. Health Inequalities team.
Yeah, we were asked to do an assessment of the service after 2 years in terms of what it's achieved versus the original business case, to see whether the targets that were included in it had been met. And the service is not a target-driven service. It's clearly a clinically human-driven service, but the cold outcomes of mission avoidance, of reduction in ED attendance were all met, if not exceeded. So I'm happy to share some information on that.
Thanks, Steve. We've also put the overall evaluation into our PPP Pathway Partnership Programme annual report, and the link is already in the chat there, if that would be useful. There's a question from Jane Wilson. Duty to refer not working, can you explain more? So Pathway did a bit of work on this last year. A lot of areas are not aware of duty to refer, that staff in the hospital don't know they're supposed to be doing it. It's better in areas that have got teams, specific homelessness teams or pathway teams. So in those areas, it tends to work better, partly because they're aware of their duties, but also because they make the links to the services. So they're making the links out from the hospital into the housing service. So things work better because the relationships have been built up. So one hand up here. This is Carol. I think we'll have to unmute you, Carol.
Yeah, that's okay. So I think for me, it's really around the use of intermediate care. So in the area that I'm in, we do take patients experiencing homelessness where there's a rehab, reablement, recovery agenda. Could you talk a little bit more about how you use intermediate care and how you support it?
Yeah, sure. Shall I take this one, team? Yeah. So what we found, what the evidence shows, is that where there's specialist intermediate care, particularly, and a pathway team, that works really well. And it's great to hear that in your area, intermediate care is being used for the people experiencing homelessness. In many areas, we find that people are not accepted, because if there isn't an onward address that can be given, people won't be accepted for regular intermediate care. So I think you're right. If intermediate care services were open to everybody in the same way, then that would go some way to helping with the problem. And of course, then you have got somewhere where you can do the discharge to assess assessments. But in many areas, that's not possible. So in those areas, particularly, pathway teams, they can then be used to help and then show up the need for specialist intermediate care. So I think it's like all of these things. If everything's working well as it should be, then that's all great. But in a lot of areas, it's not. And if you're not being accepted into intermediate care and duty to refer is not happening very well, you're not getting very far from hospital. And I think that's why lots of people get discharged back to the street again, where there isn't specialist provision.
Lovely. If you have anything on the evidence base behind that and the use of intermediate care, we can add it to our North Central London clinical model.
Great. Yeah, if you could put something in the chat, we'll make sure that we send out information about that. Thank you. Oh, someone's put the duty to refer report there in the chat, so thank you for doing that. It's early.
I've done like a expenses.
So there's a question here about Hull.
I'll get her to speak to Claire about purchase orders.
Be a good one for Gareth. So thank you this morning. I'm from Hull, but have only been in post for 1 year. Have Pathway worked with Hull, or are you currently working in Hull? I'm a lived experience coordinator.
Yes, I know Sarah. Hello, Sarah. Yep, it is Anna Darwick & Co, who I think you've met quite regularly, and we know how important the work is that they do. And hospital, that's the homeless health team from Pathways in Hull. As you'll know, they do fantastic work, and let's hope we can get some more around the country.
How do you feel, like with the community part going? How do you feel that's going to kind of have a knock-on effect?
Say that again, sorry, Sarah.
Yeah.
So the community team that join on to the hospital, part of that's gone, hasn't it? How do you feel that's going to kind of affect things?
Extremely negatively. The work that was done, as has been talked on during this meeting, in the community is very important. Sadly, I believe that we're now going to see more people coming into the emergency department needing care that the Pathways Homeless Health team was doing in the community. I think the figures will be seeing more homeless people attending. Obviously, the funding's just been cut this month, so it's too early to say. But we know the difference it makes. We might not have the figures to hand, but we know the importance of the work. And sadly, the emergency department and the services in Hull are going to suffer because of that, because of the funding being cut in half, I believe, off the top of my head. And yeah, honestly, I was very disappointed when I saw that, and yeah, it's only going to make the most vulnerable even more vulnerable now, and it's such a shame to see.
Thanks, Gareth.
Okay, thanks everybody. We're at time, and we know people have joined us before starting their working day, so I think we will finish there. Thank you to you all for joining us. Do get in touch with us, as we've said, if we can help, or if you want to have further discussions. I think some have already started in the chat there. Big thank you to all our speakers for this morning, everyone from Pathway, Gareth from Lived Experience Group, and Steve from Devon. Have a good rest of the day, and hopefully we will be in touch soon. Thank you very much.